Awake spine surgery is the term used when the spine surgery is done under local or regional anesthesia and patient is awake during the surgery. Neurosurgeons have been doing awake brain surgery since long. Similarly, orthopedic surgeons have been doing limb surgeries under local or regional anesthesia. On the similar line, various lumbar decompression or fusion procedures and endoscopic spine surgeries can be done under regional or local anesthesia, and these are called awake spine surgery. As part of the enhanced recovery after surgery movement, wherein the emphasis lies on faster recovery of the patient with reduced length of the stay, improved patient outcome, and decreasing the healthcare costs. Awake spine surgeries have become prevalent more so in the Western countries. This has become possible because of the advent of various minimally invasive surgery where the time taken for the surgery is less and the patient recovery is faster because of the reduced soft tissue destruction during the surgery. Added to that, multimodal pain management protocols, which improves patients' post-operative experience and helps them for faster discharge from the hospital, made the awake spine surgeries possible. There are various types of awake spine surgeries done. Most of the lumbar procedures are done under spinal anesthesia. There are few reports wherein local anesthesia with heavy sedation was used, not only for the decompression procedure but also for the instrumentation procedures. Various ACDF procedures were also being done under cervical plexus block along with the heavy dosage of local anesthetic. However, these were not very popular because of the lesser patient satisfaction, which is the ultimate goal of doing this surgery, and higher blood pressure and heart rate variation during the surgery. One need to note that a transforaminal endoscopic surgery will always need to be done under local anesthesia to prevent inadvertent nerve root injury while inserting the scope in the foramen. There are various inclusion criteria for awake spine surgery. The patient should tolerate awake prone position because majority of the lumbar procedures are done in the prone position and it will take about 1.5 hours. So patient should be comfortable lying in that position for that much period of time. Patient should not be having any breathing difficulty. An MIS procedure is preferred for this kind of surgery as it will have a shorter operative time. So if you look at few exclusion criteria, if the patient has a history of anxiety or BMI is more than 30, if there is a history of sleep apnea or compromised airway, then these patients are not an ideal candidate for awake spine surgery. If the degree of central canal stenosis is severe or if it is spread at multiple levels, then maybe an experienced surgeon can still do it under regional anesthesia. However, in routine practice, these cases should not be done under regional or local anesthesia. A protocol is given by Dr. Mumaneni et al. So wherein 1 gram of paracetamol and 600 milligram of gabapentin is given before the OT. A pre-procedure sedation is recommended with either midazolam or fentanyl. Spinal anesthesia is given with 3 milliliter of isobaric bupivacaine. If required, intra-op sedation can be given with the help of propofol, ketamine, or maybe dexmedetomidine. If required, local anesthetic can be infused at the site of incision. Intraoperative nausea is taken care of by dexamethasone or ondansetron. The BP need to be maintained above 65 millimeters of mercury with the help of IV fluids. In the post-operative period, pain is controlled with the paracetamol, opioids, and gabapentin. It is recommended to avoid patient-controlled analgesia so that the patient can have faster discharge from the hospital. If the patient develops urinary retention, then a bladder scan can be done in the recovery room and a straight catheter can be passed temporarily to empty the patient's bladder. Endoscopic assisted transforaminal fusion and percute fixation has been reported in the literature done under local anesthesia. So a transforaminal endoscopic decompression and end plate preparation is done. Then insertion of expandable mesh cage with biologics, which can include bone morphogenic protein or graft substitute, is inserted. Percutaneous screws are inserted under local anesthesia. This is the pictorial algorithm of the procedure wherein a transforaminal discectomy followed by end plate preparation and insertion of cage with biologics is done, and then percutaneous screws are inserted under local anesthesia. There are few advantages of doing the procedures under local or regional anesthesia as the patient experiences lesser nausea compared to the patient who underwent surgery under general anesthesia. There is lesser chances of urinary retention. Literature is not very clear about blood loss, whether it is better in general anesthesia or the patient undergoing surgery under regional anesthesia. Patient has low demand of post-operative pain medication. Their post-operative recovery is faster and the discharge is faster. This ultimately reduces the economic burden to the healthcare and to the patient. There are few contraindications of awake spine surgery. Patients who have respiratory problem like COPD or obstructive sleep apnea are not suited for surgeries under regional or local anesthesia. Patients with uncontrolled cardiac risk factor which might worsen due to the detrimental effect of local anesthetic are not ideal candidate. So in nutshell, surgeries involving 2 to 3 levels or an endoscopic procedure where we also need a neural feedback from the patient. Aging population who are not fit for general anesthesia are the ideal candidate for awake spine surgery. However, more than 2 to 3 vertebral level of decompression or instrumentation, surgery with unpredictable duration like a tumor surgery, patient with risk of respiratory compromise, high BMI, obstructive sleep apnea, pre-existing depression, or bleeding disorders are not ideal candidate for awake spine surgery. There are few complications of this procedure. If the spinal anesthesia is inadvertently given at the site of the surgical decompression, then the tiny hole of spinal anesthesia can widen because of the thecal sac retraction, and one might need to repair this. One of the common limitation of using regional anesthesia is that intraoperative neuromonitoring cannot be used. In our experience, we had been doing lumbar decompression procedures regularly under regional anesthesia. We have done a few lumbar fusion procedures also where patient was not fit for general anesthesia. Anesthetists need to be informed about the level which we are going to operate. Otherwise, their favorite level of giving spinal anesthesia is L3-4 or L4-5, which is most common site of surgical decompression as well. They need to insert the spinal needle 2 to 3 levels above the surgery site. One thing we definitely found was that the OT turnover is faster. So on a busy day, it makes sense to do few surgeries under regional anesthesia because as compared to general anesthesia, a regional anesthesia will not need the time required for reversal of anesthetic agents. One of the common side effects which we see is a lot of muscle twitching which happens during the exposure, and this can irritate the surgeon. And for the same reason, doing an MI stiff kind of procedure can sometimes be a struggle, and the muscles keep on coming under your retractor. Thank you very much.